El tema que voy a dar el día de hoy es malnutrición y desarrollo en el niño oncológico.
Today I will talk about malnutrition and development of children with cancer. Here we have the National Cancer Hospital where I work. This conference has been sponsored by Ordesa. And the objectives are to determine the numbers for children cancer today, to detect the nutritional status of pediatric patients with cancer, determine the impact of the nutrition on cancer and the therapeutic options that are available to offer to our patients. Every year in the world, there are approximately 400,000 children and adolescents under 19 who are diagnosed with cancer, and the most common ones are leukemias, brain cancer, lymphomas, among others. And in high-income countries, more than 80% of children with cancer are cured. In medium to low-income countries, this figure is lower, and it is estimated that there is a 15% to 45% of cure. Here we have a statistic from my hospital. Between the years 2014 and 2018, 1,278 cases of cancer in children under 19 were diagnosed, and 54% were in male patients. At a world level, with regard to the figures that refer to nutrition, 1 out of every 3 children under 5 have malnutrition, either due to deficit or excess, and 1 of every 2 children have hidden hunger or a lack of nutrients. And these figures make us think about how important is the situation, the status of that cancer, of that child with cancer, who can have a deficit malnutrition or an excess malnutrition, or there can be some hidden hunger. And what's important about nutrition in this case is that these children may not have the right status for a right therapy, because nutrition has a key role in the prevention of cancer, in the same treatment, and also in the recovery period, and also during palliative therapy. Therefore, the nutritional status is associated with the pathogenic of the malignant diseases, the tolerance to the treatment, and other malignancies. In high-income countries, overweight and obesity are a public health problem. And in low and medium-income countries, there is a problem of malnutrition, and all these factors have an impact on comorbidities with regard to the treatment of cancer, the impact on mortality, the discontinuation of therapy, and the quality of life. That's why we have to say no to malnutrition. And the prevalence of malnutrition in children with cancer ranges from 5 to 48%, and it can be present at any stage during cancer, from the moment of diagnosis, during treatment, and survival. In this study by Elena Hades, the nutritional status is very important, is absolutely essential at the time of diagnosis, and it has an impact on the response to therapy and the likelihood of recovery. The working group of the PODC recommends a standardized method for the nutritional assessment of children with cancer. This assessment has to be simple and it has to be low cost and be easy to implement even in environments with limited resources. In countries with medium-low income, the goal is to determine the child's nutritional status with low cost and minimal assessments. The SIOP Nutrition Working Group recommends that the minimum nutritional assessment has to include the weight, the height, the middle upper arm circumference, and the BMI. And it should detect any signs of insufficient intake or micronutrient deficiency. There should be nutritional lab tests and an in-depth analysis of the dietary intake and advanced studies of body composition if necessary and if possible. And which tools do we have available to determine the nutritional status of children with cancer? Well, first of all, we have the STAMP, the screening tool for the assessment of malnutrition in pediatrics, where we look at the weight, the height, the intake assessment, and the risk of disease. We also have the PIMS score that looks at the BMI, the loss of recent weight, and changes in the food intake. And we also have the scan and nutrition screening tool for childhood cancer that determines the cancer, the type of cancer, and associates it with the risk of malnutrition, the type of treatment received by the cancer patient, whether it's chemotherapy, radiotherapy, or whether the patient has received a transplant. And there is no sufficient evidence, however, with regard to these tools to determine which one is more accurate in its predictions. And the SGNA is a subjective global nutritional assessment, is validated as a tool to predict any complications associated with nutrition in pediatrics. However, the scan is the only nutritional screening tool that has been developed specifically for childhood cancer. This study is quite interesting by the Gabriela Villanueva group that looks at the nutritional status of, at diagnosis of cancer in children and adolescents in Guatemala, looking at the relationship to socioeconomic disadvantage. It's a retrospective cohort study with 1,060 cancer patients with different measurements, and leukemia represented the most common cancer with 51% of all diagnoses, followed by solid tumors, lymphoma, and brain tumors. And what did we find in this study? At cancer diagnosis, 47% of the children in Guatemala were seriously suffering from malnutrition. 90% were suffering moderately of malnutrition. 34% were appropriately had an appropriate nutrition. So we have a 66% of malnutrition. This is a high figure. If we compare this with what happens in highly developed countries, there's this other study by the Eaton Orgel group, where 2008 children were treated for leukemia in the US. And the percentile and Z-score were determined using the BMI for children between 2 and 20 years of age and the height for children under 2. And out of the 2008 children, 14% were obese and 6% had a low weight at the time of diagnosis. So you can see the huge difference, the contrast between Guatemala and the US at the time of cancer diagnosis. To be obese or to have a low weight at the time of diagnosis and during more than 50% of the time between the end of the induction therapy and the starting of the maintenance therapy of leukemia, in this case, results in a lower survival time free of disease compared to the lean patients. So the prevalence of malnourishment depends on different factors, such as the moment of the nutritional assessment, because very often it can be postponed by other procedures that can have a higher priority. And there is no gold clinical standard to assess the nutritional status. And malnutrition worsens when the disease advances with no nutritional diagnosis. And if we don't correct that malnutrition, then the child will continue receiving treatment and that malnutrition will continue to worsen. That's why it's important to focus on how we need a holistic type of treatment in cancer. And when we're talking about a holistic type of treatment, we are also looking at the nutritional status and how important it is to solve that malnutrition. And an early diagnosis of malnutrition and an early intervention should be our priority. The right to a nutritional therapy is a human right. This has been established by the International Declaration of Cartagena that was signed in 2019 on May the 3rd by the members of the Latin America Federation of Nutrition, and that is now having international impact on all the international societies such as ASPEN or ESPEN, and of course the African Society and many others. This is the cancer diagnosis. What tumors should make us think that there may be some major complications in terms of nutrition? Well, there's neuroblastoma. We have Wilms tumor, Ewing lymphoma, and rhabdomyosarcoma, leukemia, lymphoma, nose and pharynx carcinoma, and recurrent leukemia. So there is an approach already there with regard to the nutrition, because if we have an irradiation of the GI tract, then nausea is to be expected, and also alterations in the Z score. And we also have other interventions such as surgery or bone marrow transplant, and other symptoms such as vomiting, diarrhea, and severe mucositis that will impact the nutritional status of the patient. And when we look at the anthropometrics, we need to look at the percentile, whether it's below 10 or over 90, sorry, below 2 or over 2. Or if we look at the MUAC, whether it's below 10 or above 90, or if there is a loss of weight or a limited weight gain in recent weeks. And when I talk to the mothers, I always ask them to apply the method of the plate. How much is their child eating? That's my question. When you give them a plate of food, do they eat half the plate, a quarter of the plate? And we have Sowell's study that establishes that if the patient only eats one quarter of that plate, then that patient will have 3 times more likelihood of complications and of having a fatal result, fatal outcome. This is another study where malnutrition is associated with worse health-related quality of life in children with cancer. 104 children of 2 to 18 years of age were diagnosed with hematological neoplasia, brain cancer, and other solid tumors. Their nutritional status was assessed, and the quality of life, health-related quality of life at the time of diagnosis and at months 3, 6, and 12, using different scores such as the PEDS-QL or the PEDS-QL 3.0. And malnourishment and weight loss are associated with a worse physical and social performance, whereas overnutrition and weight gain impact the emotional and social areas of quality of life. The diet is very important. It's important to assess the diet intake, and we just have to think that children with cancer need an appropriate diet that is protein rich during the treatment, and if the diet is inadequate, then there'll be an impact on the immune status, and there'll be a dysfunction, organic dysfunction. And there are different parameters. For example, the ratio of fat 30% to 40% in children of 1 to 3 years, 25% to 35% in 4 to 18 years, carbohydrates 45 to 65%, and proteins 10 to 35%. This is the recommended intake of macronutrients. And these are all the parameters on which we can work. We can provide a dietary assessment with oral supplementation. In some cases, we also use enteral nutrition and parenteral nutrition, and we can combine different types of nutrition with a mixed nutrition, but we know that we have to obtain a diet that is as normal as possible, and only in specific cases we'll use enteral or parenteral nutrition. This is a very interesting study with 1,680 papers, out of which 47 were selected, and it was shown that children with cancer have a lower intake of energy, of protein and lipids than healthy children. And patients with less than 3 daily intakes of food have had more micronutrient deficiency. Regardless of other factors, the standard requirement of micronutrients such as vitamin E, A, and D, and minerals such as zinc and copper were not reached. The minimum requirements were not reached, and it's very important to remember that when we have a cancer diagnosis, we should look at the treatment phase, the cultural pattern of food, because there are children who look for transplants in other countries, and it's important to talk about this topic with the parents, because very often at the hospital, the children are subject to very strict diets, and they are not taking many nutrients that are necessary because the parents just want to save their lives and are being very strict with their diets. But what's important is to be able to discuss this with the parents. This is another study that assesses the nutritional status with nutritional supplements. 45 children with cancer were assessed nutritionally at baseline, at 3 months, and at 6 months through different tests, and almost half of them were suffering malnutrition, and 26 of these patients receive oral nutritional supplements. That is 55% of these 26 patients, of the patient population of 45, and 69% received a hypercaloric diet, and 8 of them, that's 31%, an isocaloric diet. And 3 months later, after diagnosis, there was a non-significant reduction of the number of patients with malnutrition. However, in the following 3 months, the number of patients with malnutrition was reduced from 14 to 11, and this was statistically significant. This is another study that is a prospective randomized study with 52 patients who were diagnosed with cancer and that received intensive chemotherapy. 33 of these patients received a nutritional supplement that included EPA apart from their usual food intake, and the other 19 didn't have any supplements, and they were the control group. And when assessing both groups through the BMI, the weight percentile, and weight, and there was a follow-up during 3 months, once monthly. And there was a reduction in the weight loss induced by cancer in the pediatric patients that were fed a nutritional supplement that was rich in proteins and energy that contained EPA. We all know the benefits of omega-3, and that is very good for the health of cancer patients. But once we have given this oral supplement and we need some enteral feeding still, what can we offer? We know that parenteral nutrition is ideal for patients who are subject to a transplant. And out of this group, there were 65 children that were initiated on enteral nutrition the day after the transplant. And 50 of these children only receive enteral nutrition, and 15 of them receive both parenteral and enteral nutrition. And the enteral nutrition group had a shorter time of recovery, whereas the group that received parenteral and enteral nutrition had a more serious reaction, and there was a reduction of the BMI Z-score. Therefore, enteral nutrition can be considered as an option for the nutritional support in children who are subject to transplants. And this was a small sample, therefore we need larger studies. What about parenteral nutrition? There are many factors that are associated with the disease and the treatment that can harm the GI tract of the pediatric patient, and this will have an impact of their the absorption of nutrients, and this therefore also affects their nutritional status. And chemotherapy and radiotherapy also impact the microbiota and the immune system, and they cause a direct lesions in the GI mucosa that is worsened by the oxygen and pro-inflammatory substances that are released with chemotherapy and radiotherapy. And many children have dysbiosis, GI dysbiosis, and when it's severe, for example, recurrent diarrhea, then we need parenteral nutrition. We also know that the human body, when it's well nurtured, can tolerate short periods of inadequate nutrition, up to 3 days in babies and 5 days in older children. However, if we have significant malnutrition or loss of weight with dysfunction of the GI tract that limit the enteral tolerance, the parenteral nutrition may be indicated before, and we need much more research to define the optimal moment to start parenteral nutrition in cancer children. In a large study with children that were severely ill in the ICU showed clinical results that were better when parenteral nutrition was started early. Finally, we have the impact of exercising. This is a study by the Martin Group with 120 patients between 16 and 18 years of age undergoing chemotherapy or radiotherapy with a control group of 58 patients. We see that the was a group that did 30 minutes of exercise during 6 months, and at 6 months there was a better respiratory response and better physical status, and that means that exercise is safe. Of course, with the relevant assessment. So by way of conclusion, we should say that nutritional diagnosis is essential in cancer patients. Malnutrition has been associated with the presence of cancer, its evolution and prognosis. And it is key to know that we should offer a nutritional therapy to pediatric patients with cancer at the right time and in an optimal manner. So if we have a cancer patient, we cannot see any malnutrition, and if there's malnutrition, we should intervene, because remember, it's like a building that's bombed by cancer, and the cancer treatment is trying to save that building, but it's important to be able to hold that building properly with different pillars, and one of the pillars is this appropriate nutrition. So if we give to each individual the appropriate quantity of food and exercise, not too much and not too little, then this will be the right pathway to health. And this is a quote by Hippocrates. Thank you very much for your attention.